Okay, in business. Welcome everybody to Grand Rounds today. Today we're going to have Kathryn Daveson talking to us on getting on and off the merry-go-round. Do we want or care for a learning health system? Without any further ado, I'll ask Kathryn to give us Grand Rounds today.
Thanks very much, Paul. Thanks for having me today. It's been a while since I've been speaking at Grand Rounds, and as some of you might know, that's because for probably the better part of the last 8 years, I've been working between a number of health jurisdictions, and unfortunately, I was always working there on Wednesday. So I haven't been able to engage in this forum for a while, but it's so good to be back. And why I'm here today is because I've recently taken on the medical director role of quality, safety, innovation and improvement. And so we are here to talk about advances in learning health system frameworks and also research methodologies that you may not be aware of that underpins our ability to inform care and move forwards as a health service. But before I start, I do want to acknowledge the Ngunnawal people as the traditional custodians of the land we're meeting on, and recognise any other families or people with connection to the lands of the ACT and region. And of course, we wish to acknowledge and respect continuing culture and contribution to the life they make in this city and this region. And I'd also like to acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending today's event. And it's a busy week of acknowledgements for a number of reasons. Today is Ida Hobbit Day. I often wear colourful dresses, but it's rainbow specifically today on May 17. And also it's Volunteers Week. So I think going forward in this presentation, it's really important to keep our consumers, our carers, and also our volunteers at the forefront of our mind, and when we think about how we're functioning in a learning health system. So I've chosen a merry-go-round as one of the themes of the presentation today. Does anyone know what this is? It's the Civic Canberra Carousel, yes. And does anyone know how it is somewhat linked to the Woden Valley / Canberra Health Services? No? So it was purchased in 1973. And it was in St Kilda before in Melbourne. And I believe, and some of you can correct me if I'm wrong, that was the year also that Woden Hospital opened and then progressed to what we know today as Canberra Health Services. So it's 50 years old, so is Woden Hospital. And so it's a nice time to pause and reflect on where we're going as a health system. And the merry-go-round is interesting because when you're at the centre, you don't really feel the pressure of everything. Everything's running smoothly. You can stand there, not hold on. You can go about your activities without much force being applied to you. But as you go further and further out, you have to hang on harder, yeah? And as you get to the edge, then you have more risk of falling off. And once the merry-go-round is going, and it's going quickly, it's harder to get back on. And I think that's a nice analogy for what we often experience in healthcare. And of course, what we're experiencing at the moment, many of us in the red area, some of us at the tip of the black, is that we're all at tipping point. We've had a number of very tough years. And going forward in recent times with the evolution of the news for the ACT health system, you know, that's tipping even more of us into the red zone rather than the black. But at some point here, we should be reflecting and working how we get ourselves back into the lower points of the black. And that's really hard when we're in the red. It's hard when we're in the black too, but that's when we have the most capacity to be evolutionary in our change processes. And today, hopefully I'll share with you some ways of trying to work that out and how we go from there to actually staying in the black. Okay, a couple of questions. How long does it take to implement sustainable new ideas or processes or evidence? Pardon? 17 years. There you go. If you've read the papers. Actually, the paper actually has quite a big range of implementation sort of timeframes. But, you know, I think it's just showing us that the journey to actually changing the care we deliver for our patients is long and complex, and often you know, filtered with traps, as we saw with the mouse before. But also in recent times, we've seen we can do it very quickly. So obviously with COVID-19, we have had a rapid change in the landscape of care for our patients. And for me personally, you know, it was transformational, and some of the things that we were able to do in real time were supported by people behind the scenes, looking at the research while it was coming through, integrating that, synthesizing it, contextualizing it from our healthcare system, and then enabling us to make conscious decisions, both clinically, politically, and policy, to be able to enact change in processes through the system. So this is just one of the pipelines of change. Obviously, not everything goes through basic scientific research, but you know, you can see where the 17 years actually maps to when you think of the whole continuum of basic research to practice. Okay, I don't think you should answer the next one. No. But how often do new models of care and initiatives work? 10%. Anyone? Anyone higher? That's pretty bleak. Yeah. 17 years is pretty long. Yeah, so it depends when you measure the success, I guess, Paul, isn't it? Yeah. So I couldn't find the old paper that I used to reference here, but it's in the teens. So, you know, I think we just have to accept and embrace the fact, whatever we're going to do, at least to start, we're going to fail. And so to fail is good because it means we're learning, as long as we take that opportunity to embrace the learning and move forwards in terms of what we do next. And often, you know, the biggest failer is best for the system, because then it can be repurposed with all the learnings and make for a better success next time when the next person has taken on your role and your post and doing the same thing. So, the learning health system is a term many of you might have heard. I presume it seems like a bit of a buzzword, and it probably is, but it was coined in 2007 or approximately around there to conceptualise how we use best evidence for collaborative healthcare choices to drive the process of discovery in healthcare in our day-to-day practice, and ensure it's being used to provide safe, quality and value in healthcare. And does anyone know how long it took this to be conceptualised for healthcare from other businesses? 14 years. So other businesses were using these concepts in 1993 in the published literature, and well before that, presumably in practice. And this started to be conceptualised in the early 2000s, mid-2000s. And then, you know, as we have more IT solutions, it became more explicit about the informatics and the policy and procedural sort of framework that needs to incentivise and align these processes within the healthcare system. So, you know, various definitions, but essentially it means how we're working together as a system to apply what we know. But in reality, many of us are barely hanging on. We're tired, and we're, I think, in multiple different camps. One of us, some of us are very much not hanging on anymore, but some of us are still holding to the hope that these systems can actually change our clinical care where we're overwhelmed. But, you know, I do like this little girl who's still hanging on despite multiple issues to what she thinks she should be providing in her life of play on any specific day. And so we're all in the merry-go-round of care. We have more patients, we have more care that we're providing. We have less or relatively less, given the care we're providing, resources. And it means many people are overcared, they're undercared, or are receiving no care. And although when we're not acknowledging that, it seems okay, in actual fact, for many patients, it's not. So to take you through the evolving sort of landscape of how we evaluate health research, I chose to use an actual case study of what's going on in our health system at the moment. And this is a case study of a unit having an increased referral demand. That's happening over a lot of units at the moment. We have more complex patients who have less clear treatment pathways due to the complexity of their disease. And so it's a not uncommon scenario. So in this particular unit, their increased community burden of patients needing care was rising somewhere between 6 and 8% a year, so quite a lot. They were also in a clinical care landscape where the complexities of the therapies that their standard patients were eligible to receive was increasing extremely rapidly, and primary care physicians couldn't keep up with the explosion in therapeutic options. And so the ability for primary care to provide the care that they would have otherwise given in the decade before was receding. And as we all are having, we're having similar service resourcing with no horizon for double the amount of doctors, nurses, etc. This unit was pretty engaged in how they were managing their outpatient services, and that exhausted all traditional pre-tertiary care avenues and optimised them. So they had given primary care health network education. They had worked out their low-risk patients who they didn't need to see to provide protocolised care for GPs. They had optimised their healthcare pathways, intake processes. And so the question for them was, in an exasperated way, how do we continue to provide care with relatively less resources? So this is not the focus of today, but I just did want to acknowledge that this particular unit was very invested in understanding their own data, and they had that set up, and it was providing the platform for the previous initiatives they'd done quite successfully in their unit to get to where they were. But still, it wasn't enough to provide the care they had with the resources available to them. And so in this particular unit, they decided to pilot a program with a new model of care that was not necessarily direct service provision. They decided to do a single site pilot in a high-risk patient population that they had clearly demarcated. So some patients couldn't be put into this system because they were even higher risk than the ones that they were enrolling. And they had a look at their data before and after their particular pilot. And they found that they had a significantly improved median disease control marker sort of outcome within 4 months. Across the service line, the patient population they were looking at. And there was a 75% reduction in direct referrals from the site that they piloted in, and it was sustained at 6 months. So after they'd left the pilot site, it was sustained. So really profound changes. And the resourcing for this was 1 session a month for 4 months. So not big bickies in terms of how we're providing care for these patients, otherwise in the outpatient setting. You know, they're doing all the right things. Funding stakeholders were actively engaged. You know, we like to assume that means they're going to pay for it at the end. But of course, even with the outcomes of their pilot, no funds for ongoing sustainable functions for this pilot were realised at the end, which was disappointing for them because they felt they had a really, you know, impressive new model of care that should be supported. All unit identifiers are, de-identified to protect decisions that were made in this example. But in reality, they felt they were on the merry-go-round as well, and they were exasperated. And it's easy to, throw your hands up at this stage and go, what else can I do? I may as well just, go to lunch because I just can't sustain what I'm doing at the moment. And although my children are at the point where I have considered an Uber driver for them on multiple occasions, I haven't quite resorted to that at the moment. So they're on the quality improvement merry-go-round. And this director is very insightful. Their service delivery benefits were acknowledged, and the gains from the new model of care, they realised on reflection when they were told they wouldn't have funding because of the sustained benefits without intervention after the initial period of implementation. They realised they were only likely to have an intensive delivery phase, and then they could move to a maintenance model after the intensive care, which was much less resource intensive, and that's when they would have the gains from the reducing referrals into the system. And so they felt they were prepared to expand the pilot without resourcing to get those longer term gains at the pain point of direct service delivery in their unit at that point in time, but acknowledging that at some point in time in the near future, they would have better gains that would enable them to do things within resources. And so what they needed, though, was to have a structured way of understanding the tipping point where further investment in resources was beneficial for them moving to the maintenance phase. And that included an analysis of patient outcomes, provider competency, but tertiary care clinical provision, sustainability in terms of those reduced referrals that they were trying to get to. And all of these things are available within the system, but they were unclear where they would find them or how they would bring them together. And so the extension of the pilot program is rolling out, and it was defined together with the organisation and hopefully supported by alternative health service research methodologies, which we'll go through in a second. And so in addition to the quality improvement merry-go-round, they're also on the merry-go-round of learning. So they've learnt something, they've changed their processes, and now they're trying to map a new course. So I wanted to talk about when we look at new models of care or things we're trying to implement in our system, how we can look at them. And I think as clinicians in med school, I don't know what you're taught at the moment, except for my lectures that I deliver, what you're taught in terms of research. And often the ANU Medical School projects are often really good at understanding what's out there when you hear what your colleagues have embarked on during medical school. But these randomised control trials are often, what we're taught as basic principles of research. So the difference slightly in these are that they're embedded into the clinical care. So, traditional randomised controlled trials are embedded in care profiles such as haematology, oncology, those type of things that are ongoing all the time and very par for the course, are time intensive, externally supported often, and, really supported by a complex structure that delivers the randomised controlled trial embedded into clinical care. When things are implemented into a health service and they're often partially resourced, but not resourced to the extent that perhaps they should be, you can have embedded clinical trials that are sort of quasi-randomised. So perhaps you only have enough funding for 2 weeks of the month. So month on, week off, month on, month off, and you have a semi-control group in the periods of time where you're not delivering care. There's lots of confounders for this example, but it's a practical approach to trying to find a group that you wouldn't be providing a new model of care for. And another two which are worth mentioning are Bayesian adaptive trials, which I'll go through in a moment, that are running at the moment in Canberra Health Services, but usually multi-site, international when they started, and we'll explain exactly what they are. And then step wedge designs, which we'll go through as well. So Bayesian adaptive trials are an interesting way of looking at the utility of care, and they're based on the principle that often we have lots of different ways of treating patients, not one that's best and one standard of care, and we have to work out which one we choose to go ahead and research. And, you know, sometimes historically we've picked the wrong cherry, and we should have chosen another standard of another treatment option that people were using in the field. And so the Bayesian adaptive trials allow us to choose multiple different treatment strategies. So for example, in my area is infectious disease. One that's going on at the moment is a treatment algorithm for Staph aureus bacteremia. So we have combination therapy with different combinations. We have single agent therapy, and essentially there's 4 options of care that people can get randomized to in these adaptive trials. And it allows us to look at a number of people. So we don't need to have 4 times the amount of people. We can have a very similar amount of people. And once the care starts to be delivered, the people in the trial, their outcomes are analysed and modelled in a Bayesian sort of way to work out if this was the effect that's going on in a larger population, which ones would likely be successful and which ones wouldn't. And then they take off certain treatment algorithms, park them because they're not performing, and enrol more people in the arms that are to be successful. And so that enables us to look at lots of different ways of caring and to feed into the areas that we know are likely to have larger gains for the patient in the system. And so these things, again, are quite complex. They need a lot of IT systems, but are going on at the moment in healthcare. This is a more practical approach to embedded trials within clinical care. And this is a stepped wedge trial where people, an institution, an organisation, a unit, whatever it might be, decides to start a new intervention, and we don't have a really tight control group, but we do want to do it across the whole organisation. And rather than doing it all at the same time, there's a stepped wedged approach. So we acknowledge that perhaps by doing something in one ward, other nurses or doctors on another ward are going to hear about it and there might be changes. But if we sort of do it in a sequential way, those changes over time might be more manageable in terms of variability of outcome. But they're all very labour intensive and need quite large systems around it. And what I wanted to touch on is how we can more commonly review what we're doing in a real-time way with less intensive inputs that are required for review. So the most basic things we look at are time series charts, and we'll go through a couple and just explain how units in our healthcare system and more broadly are using them at the moment to improve care and learn about the system which we're in. The most basic are run charts. I don't know how many people use them routinely, but certainly many units are using them at the moment. And essentially it looks at sort of what outcomes we're having in a particular condition or a particular unit or a particular service delivery line. And looking at the performance over certain periods of time, this might be weekly, it might be monthly, we can see based on previous data, which is the centre line or the median that we often chart on these things, if there's a change in practice. And you can see here, there are a number of rules that people look at as to when to think about the system and could it be changing in terms of, are we getting clustered care? Is something happening here that's providing more consistent practices that we should be looking at? are things improving or are things declining? And when we were talking about the tipping point, this is what happens in the black zone. We start to see things go off and we don't know why. And often it's a good thing, and that allows us the opportunity to capitalise early. But when things are deteriorating, it also allows us to flag and think about how we can reset the system in terms of delivering consistent care. This is a practical example. This is an example from the CEC, and this is a particular infection rate in a particular ward. And you can see that the run charts are suggesting that things are sitting off where they were previously. And because it's sitting a number of times above this area, things were investigated and system changes made, and interventions which were successful to improve things back down to a goal that they were intending to reach. And this is really what you can do when you know where you want to be, you know what your system should be performing, or there are sort of extraneous elements of healthcare that define where we need to deliver care or how we need to perform. But statistical process control charts are similar, but a little bit more objective in quantifying sort of variation and where you want to concentrate. And it tries to explain common versus special cause variation. So we vary healthcare all the time. I have slightly different, my registrar sitting in the audience, and I'm sure I have different practices to the next infectious diseases consultant that he sees next week. But what we want to try and work out for optimising care and controlling changes that are a little less desirable is special cause variation. And there are a number of ways of looking at how we're going in our system that allows you to work out when to dip in. And so we can see this is actually real graphs from Canberra Health Services. Radiology are doing a lot of work in trying to reduce turnaround time for patients in the wards, to improve discharge planning, etc., and the patient time within the health system. And we can see here, for example, this is just their normal variation. So it's going on, flowing, and nothing really to see there. But when we have special cause variation, there are a few flags, again, with various rules, depending on which ones you use, that allow systems to go, is it time to actually look at what we're doing? And for example, here in angiography, the inpatient turnaround time remarkably improved. They had, I think, instituted some process changes here, and they'd gotten to where they were extremely happy with how they were going. But then it started to sort of tail up again, and so that allows them the opportunity to get back in, see what's going on, and see what simple things they can do to get the processes back in control. And that benefits the system. It allows our patients to be discharged quicker. They get their turnaround time of reporting, allows us as clinicians to make decisions quicker on the ward. And this is another little flag for special cause variation where things are, you know, moving towards, in this case, a better turnaround time, but we don't know why. So, you know, if you're trying to look at particular points in time to understand what's going on, then you might want to choose this time and this time to see what was going well, so you can see if you can implement it at other points in times of care. But the one I really wanted to talk about is interrupted time series analyses, which many people don't know about. And it's a quasi-experimental design to which we evaluate the effects of interventions through regression modelling. And it doesn't have randomisation, which is often what we do. So often in healthcare, we have patients who receive some type of care, we do something different, and then we want to know what the effects are, but randomised controlled trial is not possible or affordable. And so historically, this is what we do. So this is an example of an intervention that's introduced, and this is what the outcome for our patients was before. So pretty consistent, pretty standard, at a higher level to whatever the change is after we implement an intervention. And what I want you to have a look at is the star. and the star is a median or average of the population results before and after an intervention. So we have a higher performance than we do at this point. And so if we want to improve care, that might be good. But essentially, if we were to report standard before and after results, we would say, tick, it's a great thing. Let's think about rolling this out. And so the problem with describing outcomes in that way is that we can see that this isn't two straight lines, yeah? So we see we've done an intervention and we haven't just changed to a new baseline. We've actually continued to have gains for our patient population over time. So actually, in terms of how you'd be looking at possibly to resource this or monitor this over time, is that with the ongoing changes, we're likely to have profound changes in our model of care. So, you know, in 6 months' time, we might have 10% of the patients we had before. And so in terms of resourcing for a hospital, that really requires strategic thinking about how we're going to use the 90% of resources that was invested before to enable us to use our resources appropriately, nursing, radiology, whatever it might be. But if we're just using moving to a new baseline, then that sort of model of care and resourcing actually would need to continue. So it now allows us to actually explain what our future needs might be based on those research outcomes. In terms of this type of intervention, this is the risky one, yeah? So if you use traditional methodologies, you'll have a median or average before and a median or average after. And if you can appreciate here, if you were to use traditional before and after methodologies, you would be showing someone that what you did had no impact, yeah? But the difference in this graph is that actually care was deteriorating before, yeah, in a profound way, and you changed the trajectory of care. So these type of analyses look at the slope of change and allow you to find differences where traditional methodologies don't show what you're trying to communicate. And this has the real risk of being ignored in the system when the clinical gains are actually quite profound. And that's an intervention that should be really supported. This is the other one, and this is what we do really, really commonly. We have a run chart, we love a run chart, we're easy to pull out standard data on whatever it is, turnaround time or something like that. And what we see, if traditional methodologies are employed, we have a pre-intervention and a post-intervention, again, like the first example, show a profound change in care. But actually, care was changing before we actually did anything. And if we had done nothing, it would likely continue on that slope, yeah? So this is really important to know as well, because this intervention had no real impact, assuming care would have continued to improve on the system, and probably didn't need intervention at that time, unless there were extraneous factors, you know, that still needed further improvement. And so these are the ones we should be questioning. Is it time to pull those resources out and put it somewhere else? And so when you're making decisions, those are the benefits of using these type of analyses in working out how we should be proceeding as a system. And I just want to say some caveats. There are caveats to every, obviously, research methodology, but this one is particularly important for seasonality. So infectious diseases, seasonality is everything. Viral seasons that somewhat may not exist anymore, but influenza, RSV, as we're seeing now, really have an impact on performance, and we have to find like times to compare to. But in example like this, which is surgical prophylaxis, there are other caveats. And the main caveat is that cumulative data in different populations dilute impact. And that happens in many sort of research methodologies, but this one particularly, because every context we implement something in is different. And so we can see in these graphs that this particular site was improving with the particular intervention and trucking along very nicely. This one with the same intervention actually was tailing off and even worsening. And this one here was trucking along like site 1, but then they suddenly had a special cause variation. And at this point in time, the investigator dipped in and went, If you don't pull up your socks, you're out of the trial. And then, people got engaged again. And as we often see, this was actually when a registrar who was driving the project left the system. Yeah, so it wasn't sustained by the institution. And so when you pop all these together, this cumulative data shows a change in outcome. But if you actually look at the particular sites, the care context was probably quite different. So how do we go from here to change? And as we were saying before, these are the points where you might want to dip in to see what the system is doing, to see if you can capitalise on gains or rectify sort of trends that are deteriorating. But the key to good decision making is not knowledge, and I'll say data, because data is what we use. It's actually understanding. And now more than ever, we're swimming in the former, and we probably have too much, and it makes us confused. But the understanding of what actually it means for the system is harder to see. And I just wanted to put this up. This is something I have in my home. It was from a surgeon who went and trained as one of the general surgeons in Papua New Guinea from Queensland after he trained in the 70s. And he was an artist, and it's called Superficial Questions. And he apparently created this piece of work because he could see people coming in, asking questions of people, asking the wrong questions in a language they really couldn't comprehend, and they weren't getting the answers that they wanted. So superficial questions lead to superficial answers, and that's where we move to more qualitative research methods. The why, the how, which take time, but is where we can really understand how the system is working and ask complex questions that actually give us the best beneficial outcome in terms of success of models of care or interventions. And just to reiterate that we do have a lot of local knowledge and capacity within Canberra Health Services. So dotted throughout the presentation, I have put some links to people in the system already that are pursuing these type of research. But the main problem is that unless we're identifying these as clinicians early, who are the technical experts in care, not necessarily the consumers who are the patient experience experts in care, external people will come in and try to fix the system. And that's not the best for you, I, or patients. And, this is obviously a joke, but this is what we're often set with. We often find ourselves in structures that are rigid and don't actually represent the care we want to provide. But it's the safest merry-go-round there is. And of course, in that context, there's many complex decisions that have to be made by people who may be looking at what care we're providing. But socialising what we're doing is really important because it allows people to come on the journey with us and understand the care we're trying to provide and the demands we have. And so this is where the learning health system comes in. Quality improvement has been around for ages and many people are doing it very well here in other areas. But I think this is where we ask the health system what they should be providing for us. Everyone is busy clinicians, and what I see at the moment is busy clinicians doing work that they shouldn't have to do because the system is not set up to support them. And by setting up a system, then we have a more cost-effective solution that can deliver for you and reduces the time to organisational change. One thing of the system, as an example with IT, is, how we can move from guideline documents to executable data that is supported by the system and set within a framework that allows us to deliver these things. And so at the moment we have data capture at our fingertips, but if we don't do it well, then we're left with lots of data that we can't use for any good purpose. And so there's a whole social technological sort of aspects of the learning health system, which enable us to go from data to knowledge, knowledge to practice, and from practice to data. There are multiple different elements, representing information as computable data, performance measurement that is contextually appropriate and meaningful, the governance of data and how it's shared, how we generate and deliver knowledge-derived advice to the system, and how we promote those performance changes within the organisation. And are we ready? No, I don't think we are. And this is just an example of some things that, you know, one system has decided needs to be in place to progress their own particular learning health system. And, you know, there's even things that we wouldn't expect to touch on today, such as genomics and things like that in the system. So we're in an embryologic sort of status at the moment, but we have the potential within a time frame, if we're all engaged, to progress that way. But the thing I wanted to finish with is the carousel in Canberra isn't all horses. So there's two elephants, one's grey and one's white. And it actually allows people to come together on the merry-go-round, which I don't know if it's very common, but anyway, there's two elephants and it can seat a number of people. And what we often find in health systems is we have very innovative people who are not very practical, and we have very good clinicians who aren't very innovative. And so what we need to do is bring people together to get the best from everyone, to actually move from situations where we don't know much about things, that aren't performing very well, that have low efficiency, to actually get into what we call this optimal adaptability corridor. But what can we do if we care or we want for a learning health system, even though all these things may not be set up? So I think we can organise communities of practice. And I know many of you in the system, I've talked with you about tricky questions and how we progress them. And they're often the situations where we have clinical equipoise. And for the medical students, that means there's no right answer. And obviously for every patient, it's an individualised approach. But we all come from different perspectives. And so bringing those perspectives together to understand the tricky questions we're dealing with is the first step that we can take. And I must say, I was a bit distressed to read a number of intern feedbacks recently in the role I'm filling at this current week. And it's not about teaching and learning. It's not about support in the clinical teams. It's all about senior specialists not agreeing on how we should progress care. And I think that represents the tricky questions we're dealing with every day. And I think we don't understand how much distress that causes our junior medical officers because they're not used to dealing with grey situations. And so we have a lot of information in the system that allows us to identify these tricky questions. We have complex clinical cases, we have incident management systems, we have emerging care issues, and we have consumer feedback who are identifying these as we go. And Girish in the renal unit said he wished he could provide more opportunities for junior people to see the complex discussions specialists have with each other, to understand that this is a normal part of practice. But, you know, those questions can be identified and then they can be progressed to how we want to investigate those tricky questions. And so what can the organisation do if it cares? Well, it has to get its act together in a systematic way to provide the structures and resources that enable you to ask the tricky questions and look for new opportunities, but providing the systems that make it easy for you to do that. And so that, I hope, will get us to get on the merry-go-round. And lead us to somewhere where we want to be in the future. And I think this is where we want to be in the future. You know, I believe, and I may be wrong because I'm obviously not a First Nations person, that we're bringing people together across disciplines. And these are the paths that many people take into different areas of medicine to ask tricky questions, come together and find solutions. And hopefully when we start that process, we'll start to get off the horizontal merry-go-round and we start to get to a vertical merry-go-round where we're just dipping into the system every now and then and finding out what's going well, what's not going so well, and that practice can just be par for the course. Thanks so much.
Thanks, Kathryn. While people are thinking of questions from the audience, Can I just ask, how well are we set up to initiate those processes now? For example, in our unit, we want to introduce propofol sedation administered by nurses in the next year or two. How do we go about setting that up to see what it's like before and afterwards?
Sure. I would presume that the new model of care would be to reduce anaesthetic resources and things that, or your
increased throughput, better patient satisfaction. They'd be two of the goals.
Yeah. So I think at the moment there are a lot of skills within lots of units, and so people can go ahead themselves. But at the end of it, you want a nursing decision on resourcing and you want a medical decision on resourcing and how that's going to look for your care. So I think in the first instance, you would have, ideally, those groups would come together to decide what would be good for them in a future model of care to start. And then if the unit itself had the capacity to know where those data points live, then that's fine. But I think ideally in future, there would be a system to actually bring those people to your unit and go, this is what we've got in the system. We can set up the structures, you start delivering the care, and we'll report back to you and see how you're going. And then at certain points, there's a decided step back and go, what are we doing here? And is it the best way we can provide what we want to provide? And is there a healthcare decision to be made at that time? And those points are set up and predetermined. So there's an expectation that everyone will engage for you as a unit to make conscious decisions about where you want to head.
There's a question there, yeah.
I just have a question. So a lot of these sort of methods, I think they're very they're kind of designed around that sort of safe to fail framework, where you've got like, oh, we're going to institute this intervention and then we're going to see if it works later on down the track. But I think that one of the issues that I sort of see in that, particularly I think the JMOs were a little bit, maybe on edge about doing things out of guideline, out of recommendation, is that, you kind of need, with your indemnity and all of the negatives that can come of, getting in trouble for making the wrong decision, for making what is not gold standard practice. You make decisions like that, and it can come back to bite you. So you kind of need, I guess, in healthcare, this sort of fail-safe approach. But if you have a fail-safe approach rather than a safe-to-fail approach, you actually end up getting nowhere. Guidelines never change. You kind of don't get anywhere. So how do you navigate? Finding a medium where people can feel comfortable, despite these sort of legal and ethical ramifications for them personally? How do you navigate creating a system that is adaptable and allows change and has these safe-to-fail mechanisms?
Sure. So I think we always have an ethical framework in which we provide all of these things, and some things don't need an intensive ethical framework around it. They may be low-risk interventions that are used, but often it's the change is starting to take place because we're identifying problems already. Yeah, and so the assumption is that things will stay the same or improve. Most of the time, that's not always the case. But it's usually because there's an issue identified already where guidelines or care isn't fit for purpose for the individual patient population or consumer. So I think in terms of the broader issue, there's always an ethical framework and good clinical practice in which we work. And those are the frameworks which allow us to investigate new models of care. Some systems within the hospital already have an ethical process set up as day-to-day practice to allow that to happen. Not all of them do, but that is also an avenue that people can have. And then you have third parties reviewing what is reasonable for patient care in terms of change.
And how is this disseminated to the GMOs?
What particularly? Sorry, what?
is what, sorry. How is the information about how to modify and enact change and sort of be responsible for identifying areas which could benefit from change? How is that accessible to JMOs who
Yeah.
you know,
Oh, I don't think it is. Is that I don't know, is that a fair
Yeah.
comment? And I think, those discussions have been trying to evolve in terms of, particularly units that have these set up as already, is there a role for the junior medical officer to monitor that for the unit, how we engage with the pre-vocational sort of office in terms of those initiatives or opportunities. And I think as units, it's a great opportunity for a JMO to get involved and set up, assist in setting up some of those systems and, maybe have a more sustainable approach if that's how they choose to proceed.
Okay. I think we better draw the session to a close, and I'd like you to join with me in thanking Kathryn.